Cannot speak and do that at the same time. So it's wonderful to be with you. I know over the past several weeks, if you've had the opportunity to participate in this webinar series, you have heard so much about digital health. And I'm going to shift the focus a little bit today and really focus on my area of expertise, which is the rural geographic differences in health outcomes and also digital access and what that potential looks like. So it's going to take me a little while to even mention digital health in my comments. And really, this is driven by the fact that if you haven't heard, we have some really great data to show that your zip code is a better predictor of your health than your genetic code. Where you live often determines health outcomes. And location does influence digital health access and health equity as well. So, my focus within the Maryland State Office of Rural Health is, of course, rural populations. Here in Maryland, your State Office of Rural Health is situated within the Maryland Department of Health. Because I have the floor, I'll take just a couple seconds to tell you about state offices of rural health. We are one of 50. Every state has a state office. Um, every state office of rural health has three overarching goals. The first, to really serve as a focal point and state clearinghouse for collection and dissemination of rural health data. We provide coordination of health activities, helping to avoid duplication of effort across the state. We also provide nonprofit and public entities technical assistance to access federal and state resources. So, your State Office of Rural Health, if this is an area that you have interest, is really here to provide technical assistance to connect to the types of data that I'll talk about today, as well as technical assistance to access capacity building, financial resources across the country. And the walk that I will take you on today will provide some background on rural Maryland, both the geographic and demographic landscape. Will provide an introduction to health outcomes and how they look a little bit different in rural than Maryland as a whole. We'll also look at assets and challenges in rural Maryland. And then we'll eventually come around to digital health potential and considerations. Um, I'll provide some opportunities and resources and then really open up for discussion any questions that you may have. I'll aim to really slow down in each of these areas. Oftentimes, I have about 15 minutes to discuss everything rural in Maryland's health landscape. So I'm excited to be able to slow that down a little bit for today in our hour together. Most definitely, you have your own um, lived and professional experiences in rural. What I'll talk about is not the same for everywhere. And I think you'll see in my conversation, there's a lot of juxtaposition. For instance, assets, challenges. The data looks really great here, not so great here. It's different as we dive deep down into the jurisdictional level. So you'll see I aim for a balance here, and I welcome in the chat any differences of experience. Please do share your um, experience and expertise as well. So let's dive in first with really a definition of rural. There's a wide variety, different at the federal and state levels, a variety of definitions even within the federal landscape. For instance, the US Census Bureau really labels urban, but anything that's not urban is rural, and it is never defined as such. It's just non metropolitan. The US Office of Management and Budget defines rural areas a bit differently. We tend, as a state office of rural health that has provided funding through Human Resources, Health Resources and Service Administration, HRSA, we tend to follow HRSA's definition that's available through the Federal Office of Rural Health Policy. And that definition utilizes the US Census Bureau, Office of Management and Budget, but it also incorporates some additional nuance with rural urban commuting area codes or RUCA codes. And so if we look at that federal definition, and I'll show you it on a map in just a moment, you'll see that it's a relatively small land area that is considered federally defined as rural. Just six whole jurisdictions and portions of four additional. And that really represents a relatively small population as well, about 230,000 Marylanders that are federally designated as rural. Our state definition is a little bit different. It expands and encompasses 18 complete jurisdictions. So you can see that here on the map. So those bright pink areas that you can see are federally designated as rural. And then the horizontal bars, and I see a note that the slides aren't changing. Is everyone not seeing that? Okay. Thank you so much for that update. I can't see all the chats as they're coming in, so definitely help me out there. Those horizontal lines are going to be the 18 jurisdictions that are state defined as rural. And the state definition comes from Maryland Code in Comar and really bases the definition on shared history of these areas, uh, economic background in agriculture and production. And they are what you would expect them to be. Everybody but the middle swath of Maryland there. So 18 jurisdictions, excluding Baltimore, Baltimore City, Anne Arundel, Howard, Montgomery, and Prince George's counties. You will see Allegheny County gets its own little blue color. It is not overarchingly defined by the federal government as rural. However, it is often slated as an exception to the definitions because of its state prison population. So, Allegheny County is often eligible for rural funding, but it is not officially determined to be rural. To look at the map in a little bit of a different way, you can see Rural Maryland Council is a fantastic partner in providing a voice to rural areas in Maryland. And you can see here again our 18 jurisdictions in solid green. And then they also add in this level of semi rural, suburban, and urban. Now, when we look at that state defined rural area, and why rural really matters, certainly in land mass, but also we see 1.9 million Marylanders live in these 18 jurisdictions, about 29% of Maryland residents. And the rural population does tend to have some very similar aspects whenever we look at demographics. So, our rural Maryland population does tend to be older, less educated, and less income than the state as a whole. Additionally, the rural areas tend to be less racially and ethnically diverse. We'll talk about that in a couple of moments and why that matters. Certainly, as you look among regions, diversity prevails at the jurisdictional level, and it does have to be considered in any kind of programming around rural health efforts. You can see, for example, our state as a whole has about 16% of our population age 65 and over. If we really dig in deep, and we can see the Eastern Shore is at 23%. If and Western Maryland also a relatively high percentage. So within rural, there is diversity. Within jurisdictions, you will see that as well. We'll talk a little bit later on in the conversation about your far right hand data here, the percent of broadband internet subscription. And we'll note some differences again in the jurisdiction level among these regions. So we can also dig in deeper and utilize that federal versus state definition of rural as a degree of rurality. So let me show you that a little bit more here. So if we utilize state designated rural, federally designated rural, we tend to see demographics that create social determinants of health, adverse impacts on health, um, be more substantial in the federally designated. So, for instance, if we look at percent of poverty within jurisdictions, our Maryland average is at 10%. Our state designated rural, slightly higher at 10.8%. If we shift to our federally designated, we see 12.5%. And that's a common theme across data that if there's an area to be more highly vulnerable, we see it in our federally designated population, even more so than the state designated. And as you're all most likely well aware, those social determinants of health can certainly lead to poor health outcomes. Lower income, less access to transportation, food insecurity then leads to poor health outcomes. So these connections start to be built. And let's talk about some of those health outcomes. I said I'd have a lot of juxtapositioning, and my next statement is certainly that. The United Health Foundation's America's Health Rankings report places Maryland at 10th highest state in the nation for health outcomes data. We do pretty good when we are compared across the nation. And the state generally ranks high in additional aspects in that kind of report: physical environment, clinical care, health behaviors, on average, look pretty good compared to the nation. But as we dig in a bit deeper, we certainly start to see that gaps clearly exist, um, especially in those social determinants of health, specific disease burdens, and geography. So, in spite of being ranked 10th in those selected health outcomes, we can see, for instance, Maryland ranks relatively low in relation to drug deaths. At the national level, that rate is 21.5 deaths per 100,000. Our Maryland number is 38.5, next to that 21.5. So, significantly higher number of drug related deaths here in Maryland versus the national level. And so, always encouraging, dig a little bit deeper. If there is a particular disease area or population that you have interest in, always dig a little bit deeper into that data so that you can start to see how that data lines up relative to other areas. And no chart on the screen quite yet. You'll get some more data in front of you in just a moment. So, I will show you a chart though on some of the protective health barriers that we see in rural Maryland. So, if we look at rural Maryland against the averages in the state, we often see great protective health outcomes related to healthy beginnings. Um, so, again, you read this chart, percent babies with low birth weight as a state, that number is 8.9%. We see low birth weights in our state designated rural and federally designated rural areas. Same with percent of early prenatal care. We have increase in those percentages in rural areas. Higher percentage in dental visits or having a primary care provider, or lower uninsured ED visits. All of this area, Maryland, rural Maryland seems to have some protective factors. However, we can also see that there are some detrimental health behaviors as well. So, our percent of not overweight, obese, our percent of adults who currently smoke, percent of affordable housing, all of those numbers don't look as great in rural Maryland as they do for the state as a whole. And that certainly over time leads to health outcomes such as life expectancy really being the ultimate outcome of detrimental health behaviors. Here you can see life expectancy does decrease in our rural areas versus the state as a whole. One way that we can look at these, and the state has really put a great amount of value on preventive health, is looking at data related to preventable visits to the emergency room. And we can use that somewhat as a proxy of the better preventive health is in the community, the greater health access is. That should, in turn, lower the number of visits to an emergency room for preventable causes. So you can see across that top row there some of those potential preventable causes of visits to an emergency room if a chronic condition is well managed in the community. So, asthma, dental care, diabetes, hypertension, mental health. Really, here, mental health and dental care are highlighted as a top chronic disease causes of emergency room visits in Maryland. Um, and if we really look through our rural and our regions by rural designation, you start to see some significant differences experienced within those regions. Whenever we talk about Maryland's health outcomes on a national level, we often are able to say if we're looking at geographic differences in health outcomes, rural Maryland often stands in the same rankings on health outcomes as Baltimore City. Um, so you can really start to see this isn't a rural only story by any means, but it is the focus area of what I work on within the Maryland Department of Health. Now, I didn't include in this slide deck any specific health outcomes related to cancer burden, stroke, heart disease. But again, if there's a particular area that you have interest, I will always recommend dive into that particular area and look among jurisdictions, regions at that data. So it's also important then what kind of infrastructure creates both these protective factors and detrimental health factors. Um, and that's where we'll lead into next in this conversation. This is certainly an area that all of you have lived experience. So let me make sure my chat is up here and ready to go. And I'd love to see your input on this topic area as well. So I pull from my experience working across Maryland for about the past 2 decades, and also the collective experiences of Office of Population Health Improvement within the Maryland Department of Health, and the list um, that really gets us started, but is by no means the end all be all of assets in rural Maryland. Um, I think one of the biggest structure benefits I see in Maryland is our decentralized infrastructure. Here in the state, we have our state health department, but within each jurisdiction, we have a local health department that's able to tailor programming to specifically reach the residents within their jurisdiction. That is certainly not the case in every state. So I certainly see that as an asset. We have our decentralized infrastructure with a tailored local approach. In rural, when we look at places that just don't have a volume of population We do tend to see folks need to be jacks of all trades. They need to be really innovative and flexible when necessary. So, for instance, if I keep thinking about local health departments, in a local health department in Montgomery County, for instance, you may have bench strength among your nurses who are doing colorectal cancer screening, outreach, and case management. And you might have five of those nurses. We can't say the same in a Kent County. And so, if one of those nurses wins the lottery, has leave from the office, there are others who must step in to areas that aren't necessarily their area of expertise. And so that creates across fields, across healthcare environments, a need to really be able to step in and fill shoes in order to keep healthcare focus moving forward. And that certainly creates this robust history of community support and innovation. Some of the best and most out of the box thinking that I have seen has been in rural Maryland around okay, we don't have XYZ. What partners can come together to really patchwork exactly what our residents need in order to meet whatever the identified necessity might be? We certainly see this quite a bit in housing and food, um, ensuring that there's access to all of those social determinants of health. That leads into that networking and collaboration with common goals. Not every organization has the same goals. And so there is a push to have the conversations to say, what are we working toward that is very much the same, which would be improved health, reaching health potential for every one of our residents. We also see even more so in our rural areas um, a spirit of volunteerism, um, such as um, volunteering for health transportation and a cadre of folks who may deliver meals through Meals on Wheels. Certainly, emergency management systems, volunteer fire, um, and folks that we need in emergencies. And then we do a changing landscape, admittedly, but there are state and federal resources that are able to back up those local resources as well. So please definitely use the chat. What other assets do you believe you've seen in rural Maryland when it comes to health related, also? Again, there is a balance. Some of these assets can also be seen as challenges as well. But let's talk about those as also. Um, in Maryland and across the country, certainly we're going to see in challenges geographic diversity. I think something that most Marylanders love about this state is that we can be in the mountains in the morning, and by evening time, you can be sitting on the beach. You can be in the snow or not in the snow. We can access DC and Baltimore, but we can also be by ourselves and shout in the woods without being heard. That geographic diversity can really create some challenges as well. It does mean that we really need, for instance, when it comes to preparedness and response, very different planning in Worcester County versus Allegheny. There are going to be different cycles of tourism and different cycles of certainly weather. And so all of that planning needs to be a little bit different depending on where you are. And that's not a rural specific issue at all. Terrain can certainly create interesting situations for health as well. I know I don't plan on doing travel from State Center at Maryland Department of Health out to Garrett County after the beginning of October. But those folks who live in Garrett County still need to seek out their providers for maybe they can hold off on some preventive care during those months, but chronic care management still needs to happen. Certainly, acute care, they're not going to hold off on non elective surgeries. And so, those are certainly identified challenges. We can you can certainly imagine if you do live in a more urban or suburban area, you can imagine though, um, places like Nanjamoy or Accident, Maryland, you can have some isolation, both physical and social. Again, that can happen just the same in Westminster as it does on Smith Island, but it can be a bit more frequent in our rural areas. Earlier, I mentioned that we do have less heterogeneity in racial and ethnic disparity, or ethnic, racial and ethnic backgrounds in rural Maryland as opposed to the state as a whole. That can sometimes pose a challenge as populations are smaller in general for rural and racial minorities will be even smaller in our rural areas. That means that organizations who are serving those populations need to really think about them. And those populations need to raise their voices even more in order to receive the care that they may need. In our rural areas, we do also, and this comes into play when we talk about broadband access, we do have aging infrastructures, um, roads, towns, waterways. We also deal quite a bit more with private water, sewer driveways. And so that can certainly be a challenge when we talk about truly hard, tangible connections in order to have digital connections. Broadband, cell coverage, limitations, that should not come as a surprise whatsoever. Limited healthcare facilities, staff, specialists. I do want to spend a little bit of a time here um, talking about our health professional shortage areas in Maryland as they're federally designated. If you are thinking about digital health access, if you're going out for any kind of grants or financial resources related to healthcare workforce, rural, HIPSAs can become very important in that as they are a federal designation um, in rural and in urban areas. So let me talk a little bit about the a state federal partnership to identify areas within each state that have defined health professional shortages. So each area, each jurisdiction, census tract receives a score in their federally defined health professional shortage area, either zero, they have plenty of coverage of health professionals, or up to 26, they're in the most need. So in this map, you'll see the darker shade is when an entire jurisdiction has been determined to be a shortage area by the federal government. And then the lightest blue would be jurisdictions or areas that don't have any health professional shortage area designations. You can see rural Maryland. You can picture this against the map that I showed you earlier. Rural is certainly darker blue than our urban areas. As of the end of March in 2025, HRSA's data around HIPSA showed that we have about 1.1 million folks who are living in a primary care health professional shortage area within the state. In order to make this entire map that beautiful light blue, we would need about 282 additional physicians serving the state. We can also look at this map, and you can see it gets a little bit darker when we look at mental health provision. About 1.5 million residents live within a mental health professional shortage area. 82 professionals would be necessary to close those gaps. And then dental care, HIPSAs are also a thing as well. And you can see about 1.8 million population within health professional shortage areas for dental. So, regardless of the meeting that I've gone to in, say, the past 2 to 3 years, health workforce comes up as a challenge no matter the area. And you can see that playing out in the health professional shortage areas or HIPSAs. And it's certainly an area, no matter our progress, our built access around digital health, we'll need a workforce to support it. So, going back to our challenges, certainly we see workforce as a challenge, limited facilities as a challenge as well. For instance, not every specialty for healthcare can be in every place. We start to have this real challenge of there needs to be enough volume of cases in order to fund, for instance, a neurologist in a certain area. Um, and so we see across the country a real vulnerability of, for instance, hospitals in rural areas. Here in Maryland, we've certainly been protected by Maryland's very unique funding infrastructure of an all payer global budgeting system for our hospitals. So we don't see quite the same level of vulnerability as other rural hospitals across the country. As we shift from to preventive care and a value versus volume, that other states really do need to see volumes in order to best serve and keep their hospital doors open. If you have any other thoughts there, please put those in the chats. Um, we also, I mentioned, for instance, in an asset that we have a real spirit of volunteerism in rural Maryland, but that can also be a challenge. If we're relying on volunteers, what do we do when there is a larger scale issue? When those volunteers are mixed up in a crisis as well. Um, State and federal also, I noted that as an asset, but they can also a reliance on those resources to be the be all end all, if that comes to the case, can also be a real challenge. And we certainly saw during, for instance, the COVID-19 public health emergency an exacerbation of social determinants of health. If we see turning tides in the economics within Maryland, that can be an exacerbation of the social determinants of health. So we certainly have a strong list of assets identified within rural Maryland. We also have challenges that we continue to work out. I'm going to pause for just a moment. Any comments, additional thoughts that any of you would like to state around assets or challenges? Okay, then let's get rolling here on the digital health part. Um, Telemedicine, electronic health reporting, remote monitoring, apps, AI diagnostics. There is great potential to start to overcome some of those challenges, like uh, geographic isolation, like um, lower income paying jobs or hourly wages, and not being able to get as much time out of work, being able to take those calls from the parking lot at work versus taking time out of the day. There is great promise and potential in digital health and its full implementation. Um, and the Maryland Healthcare Commission has been called upon to do a couple of studies already around potential impact of telehealth here in Maryland. And they state that evidence suggests that telehealth can be as effective as inpatient care for some somatic conditions, can enhance patient outcomes, enhance patient satisfaction, adherence, reduce hospital admissions. So, all of those kind of ticks that we know can lead to better overarching health outcomes. We've got some cool examples already in Maryland, in rural Maryland specific, that are using telemedicine and the opportunity, not always necessarily to just um, allow accessibility from a patient to a provider, but also provider to provider. For instance, at Garrett Regional, there is a telestroke program. West Virginia University is able to provide telestroke consultations and facilitate local care and patients staying within Garrett County and not make unnecessary transfers in the ambulance, for instance. Um, 65% of the time across all of their participating hospitals. So there is great value and trust built when a patient's able to stay in their home hospital within their community and not be transported hours away from their family, their home, what they may know best, and where they might feel the most comfortable. And we also have the opportunity for our hospitals to be that hub as well. So Garrett Regional receives consultation on in the telestroke program, but also they're able to provide care out. They have a virtual cancer care and chronic disease telemedicine program where they provide specialist care from a hub. And they are the hub and able to reach out and see patients, talk to other providers in other areas as well. So, some beautiful potential there. And we see, you know, digital health potential includes enabling remote care, enhance efficiencies, increase access, decrease health outcomes. Um, we can see that really can help start to override some of those noted challenges: the geographic diversity, weather, lack of infrastructure when it just can't be, healthcare facility shortages, specialties. We also see on healthcare workforce, a connection to other providers can help build camaraderie that if you don't have another one of you in your area, you can imagine a physician could start to feel really burnt out and the world on their shoulders. Telemedicine does allow much more interaction with other physicians that can lift some of that burden. And as we talked about, also the social determinants of health. We do see, um, for instance, our state definition of rural really built on that agriculture um, economy. And I often hear our farmers aren't going into the hospital to have XYZ taken care of. They don't want to take the time during harvest season, for instance. And so the ability of a telehealth appointment, maybe that at least gets them in the door and having a conversation versus a delay in care. Some other MHCC, Maryland Healthcare Commission work has showed use of telehealth can address disparities linked to geography, bridging the gaps to timely care, improved care coordination, monitor and treat at risk populations, expand population health programs, reach underserved patients. All that being said, we discussed that. This is all true if access is equitable. And so there's a lot that comes into play. Over this series of conversations by Marylanders online, there have been a lot of great conversations. I remember Lowe a couple of weeks ago talking about the importance of knowing the individual that you're working with, not making assumptions just because someone is XYZ or appears to be ABC. Um, and so that kind of comes into play at that individual and group level. And I'm just going to talk about two examples of system and state questions or considerations, I should say, within the digital health access potential. And the first one is around this concept of digital redlining. And digital redlining, this concept is named that based on historic systems in the 1930s designed to prevent marginalized communities from accessing home loans. We also see that we have examples of this digital redlining practice where it perpetuates inequities based on, again, neighborhood income, race, rurality, um, and this underinvestment of broadband because it'll cost too much or those folks aren't going to use it. We're not going to make the profit if we do this, that, or the other thing. And so we see specific examples, for instance, in tier flattening is the terminology, or charging those with slow, unreliable, non existent internet services the same rates as those with better access. Targeting specific advertisements to folks based on these kinds of factors like income, race, rurality. And we see gaps in online delivery services. And certainly you can see this in running broadband, things like that. And I said I would come back to this thought around broadband access. So, in earlier slide, you saw about 86% of Maryland, on average, has access to broadband internet access. In Western Maryland, that's significantly lower, 77 versus the 86%. Baltimore City, about 75%. Baltimore City most definitely falls well below its regional percentage. Um, so, certainly, these kinds of things can be going on. We have some potential systematic and local approaches. First and foremost, identifying and addressing inequitable practices, um, supporting communities with last mile broadband. We have fantastic work being done in the state office of broadband. Rural Maryland Council has done quite a bit of work around last mile broadband and what does it take to reach those long farm driveways? What does it take to reach the smallest of small community centers in rural Maryland? One concept is really opening access to private spaces in public areas. So, for instance, in the 2024 legislative session, there was law passed that every school will need to have a private space that students can go for behavioral health visits, telehealth visits with their providers. Whenever we think about that, there are considerations. For instance, who funds that space? What do we take that space away from in order to make it available? What kind of safety measures do we need to put into place so that if someone is having a behavioral health um, provider visit in a public library and they're in crisis, who is available in order to facilitate a call to emergency services if necessary? All of those considerations do come into play as we consider how do we ensure that digital health is accessible and equitable. Certainly, asking the questions around social determinants of health, um, more so than simply asking, do you have a phone? Do you have a telephone? Let's sit down with it to see if it can access all of the technology that I'm prescribing to you. Um, and just like we talk about in public health, making sure that the right care is available at the right time in the right place, same idea. Making the right devices available to the right person at the right time in the right place. All of this can start to really think about that digital redlining. And I'm going to wrap up with a quick conversation as well about additional considerations. In this legislative session, you may have tuned in to the Preserve Telehealth Access Act of 2025. It really tackles issues such as audio only versus audiovisual technologies, payment parity. Should providers be paid the same for producing telehealth visits as they do for in person visits? And there is some fantastic data coming out about audio only versus audio visual. Are they of the same quality? Because we also don't want to create inequities by making something accessible that isn't the same quality. And so the Maryland Healthcare Commission has put out some great work in that area as well. Um, the law did pass, and so it did maintain audio only as an option and payment parity um, permanently within the state of Maryland for our Medicaid providers. So if you have interest in this area, certainly dive in and find out more. I also want to give you, I've mentioned a couple of different resources along my conversation, such as the Maryland Healthcare Commission. The Mid Atlantic Telehealth Resource Center is also a wonderful resource on all things telehealth related. And they have an upcoming August 1st event, Bridging Rural Communities, Telehealth Innovations for Appalachia and Beyond. They've got a great focus on rural health within the work that they do. So I encourage you to click on that link in the PowerPoint when you get it. Rural Health Information Hub, or RHI Hub, also a fantastic resource for finding all kinds of data related to rural health and specifically digital access as well. And last here, the Maryland State Office of Rural Health does host a quarterly statewide telehealth interest group, bringing together a variety of folks. I think we have more than 80 on our list now, usually a much smaller group to come to those calls from academia, from tech, from government, to really talk about all of the topics telemedicine related that they're interested in and what they're grappling with. When we talk about considerations, there's so much around policy as we allow telehealth. Do we permit controlled substance prescribing to patients whom have never been seen in person? All of those big questions. So some of those get discussed on that telehealth call. I will stop there because I'm pushing my time and I want to make sure I'm seeing chats and a lot of conversation back and forth, which is awesome. Any specific questions that you all would like to ask that I can at least provide some response to as we wrap up our hour?
Hi, thank you, Sarah. I do have a question I see here in the comment, which I'll read to you. And this is from Nikki Savoy. In the aging and disability community, falls prevention is also a common health challenge. I've noticed, was wondering if this gets tracked across the state.
That would be something that I have to look at in particular, but anything related to preventable injury and death most certainly does. And I know this is a large conversation in particular within community housing and development. Might be a great resource for that type of data because they're often looking at um, it is a wonderful thing, very data based, to keep folks in their homes as long as possible so that they can age in place. And that is exactly when that falls and falls prevention comes in. Um, So, yes, I'm sure there is data available, especially when a fall leads to a more traumatic outcome. Thank you for that note. And we see that that's going to be an issue in our rural areas where we have older adults and they're becoming older as we think about boomer generations and younger folks staying in more urban areas. We need to have that infrastructure in place to allow for as much aging in place as makes sense, but also keep folks safe. Good question.
Please feel free to use the chat to ask questions, or you can also raise your hand or come off mute.
Great comments in the chat. Thank you for sharing your contact information as it became appropriate.
All right, having this open for about 1 more minute. Does anyone have any final questions for Sarah? All right, I don't think we have any more questions, Sarah. Well, thank you so much, Sarah, for your very insightful and informative presentation. We really all appreciate it. Before you all sign off, I'm going to share my screen really quickly just to close out. All right. So as we wrap up today's webinar, a heartfelt thank you to everyone who joined us, to all of to our presenter as well. Your energy, engagement, and commitment to advancing health and access and technology is truly appreciated. Before we officially close out, I want to share a few quick reminders about our remaining webinar series. So continue learning with us about the future of health and technology. We have, let's see, 3 more sessions. Yes, we have 3 more sessions before the conclusion of this webinar series. And our next session is on June 20th from 11 a.m. to 12 p.m., which is next Friday, on policy, health, misinformation, and public trust. And the presenter for that session will be Dr. Tati Warren. So you can use this QR code to go ahead and sign up or register, and you could also visit our website for the registration link. And you can also get in touch with Marylanders Online through our website. Also, we have an email, marylandersonline@umd.edu. And you can also contact us through our toll-free tech helpline. We're open on Monday through Friday from 10 a.m. to 8 p.m. and Saturday from 10 a.m. to 5 p.m. Additionally, our program is on all social media, including Facebook, Instagram, LinkedIn. And we also have a newsletter sign up for you so you can find out more information about our upcoming conferences and webinar sessions. And then please look out for a follow-up email from Marylanders Online so you can complete our post survey for this session. You can find the QR code right here on this slide. So if you could just scan it and then fill out the post survey, we really do encourage everyone to do that. Or you could find the link in our follow-up email that we will send out. And I did see a question about the recording. So yes, this will be recorded and added to our Marylanders Online YouTube page. And there is some contact information in the chat, so please feel free to utilize that information as well. And finally, we hope you leave today feeling more empowered and informed. So we hope you all take care, enjoy your Friday, and we look forward to seeing you at the next session. Thank you, everyone.
Thank you so much.